Good afternoon, everybody. I'm Dr. Pratik Tande, Chairperson of the Endocrinology Committee. Warm welcome to the respected dignitaries and faculty who are here for today's event. Today, our focus is PCOS, and there have been, as I was just remarking, we started today. Probably more than 1,000 programs have happened on PCOS over the past 2 to 3 years. All of us are pretty much up to speed on what is the theory behind it. But how does that translate into practice? To bring out this perspective, we felt it's necessary to do a practical case-based panel discussion, which is the way we are going to do today. So before we begin, let us start by offering our gratitude to the OMOGs and his bearers. Next slide, please. I'd like to pay my respects to our president, Dr. Nandita Palshetkar. Madam is the president of OMOGs. She has served as the president of FOXC, IAG, and the Mumbai Society in the past. Currently, she is also vice president of ISA. Thank you so much, ma'am, for giving us your blessings and guiding us, supporting us throughout this pandemic period and being there for us in all our academic activities. Next slide, please. I'd like to also express my gratitude to the Secretary of AMOX, Dr. Arun Nayak. Sir is a fabulous vagina surgeon and a distinguished academician in his own right. Thank you, sir, for always being there for us. Next slide, please. At this stage, I'd also like to express my gratitude to the ICOG office bearers, our chairperson, Dr. Uday Thanawala, and the Secretary of ICOG, Dr. Ashok Kumar, for granting us the ICOG credit point for today's event. Thank you very much. Next slide, please. As I began, we are today going to talk about how we manage PCOS and how to translate the theory into practice, the challenges and dilemmas that we as clinicians face. And for this, we have a host of stalwarts from all across the country. The very first of these is Dr. Rosa Muriel. Madam has served as a vice president of FOXC in 2014. She's a fellow and also a member of the governing council of ICOG for several years. She also served on the board of trustees of HUKUQ from 2021 to 2022. She's a FIGO representative at the FIGO World Congress in Rome in 2012. She's a WHO consultant and an expert panel for making global guidelines on adolescent sexual reproductive health in Geneva. Has several awards to her credit, including the DC Datta Best Publication Award, also awarded the Neruda Rajan Prize for the Best FOXC Committee Chair in 2010. Over 100 peer-reviewed publications. She's personally co-authored 4 books in OBGYN. We're very proud to have Dr. Rosa much for spending time schedule and being. The next person on the panel is a very dear friend, Dr. Jyoti Bali. She is a reproductive medicine specialist, super specialist, I should say, ex-consultant and unit head at Fortis La Femme in New Delhi, founder secretary of the Delhi Gynae Forum, the Central Zone, vice president of BGF Central, past secretary for Delhi ISA from 2019 to 20, past joint secretary of National IMA Women's Wing, several awards to her credit, including the Nav Shakti Award and the National Women's Health Excellence Award. Thank you so much, ma'am, for joining us. I've been told that we have a couple of cases and will join as a week. We also have with us Dr. Vani Puri Rawat. She is a consultant OBGYN from Ghaziabad, North Zone Coordinator for the Sexual Medicine Committee of FOXC, Secretary and Treasurer also of the Ghaziabad OBGYN Society in successive years, Secretary for IMA Ghaziabad for 2019 to 21, a Joint Treasurer for the IMA UP State, and somebody who is very sought after as a panelist whenever we do events. So thank you, Dr. Vani, for joining us. It's always a pleasure to see you. Next slide, please. We have with us Dr. Shweta Kaur Jha. She is an infertility specialist practicing in Indore. She is known to be a very good academician and an excellent clinician. She has been awarded the B. Nagaraj Gold Medal for General Proficiency in her formative years. Her passion for reproductive medicine has made her pursue the FNP in reproductive medicine, which she was awarded in 2010. Pioneer in setting up and successfully heading NP's first NEBH accredited ABF lab. Also been conferred with the Chikitsa Ratna Award for her social work in the field of infertility in 2007. Thank you, Dr. Shweta, for joining us. I think she's live on the OT from what I saw a little while back, and she will join us as and when she is free in between cases. We also have with us today Dr. Nilima Thakre. Madam is a very distinguished and senior OBGYN from Amravati, Maharashtra, practicing since 2008. She is the immediate past president of Amravati OBGYN Society, treasurer for Mission Pink Health Wing of IMA Maharashtra State coordinator for the FOXI Oncology Committee, also served as the treasurer of the AMOX State Conference, which was held in February of 2020, a different era when we used to have physical meetings. She's also served as zonal coordinator of AMOX in the past, joint treasurer of the State AMOX Conference in the past, several awards including the Shailaja Chaudhary Award for Academic Excellence, invited faculty for several events, and she also writes for FOXI and AMOX in various publications. Thank you, ma'am, for joining us. Next slide, please. We also have with us Dr. Riti Desai. Madam is the West Zone coordinator for the FOXI Endoscopy Committee. She is a youth council member of the Mumbai Society, also served as the Yuva League last year, member of the FOXI Endocrinology Committee. She is uniquely a certified medical writer and a peer reviewer for our FOXI journal. TOG has several publications and chapters, many awards to her credit, including the Best Youth Council Member Award for Youth in Mumbai Society, the Shantabai Gulabchand Award, and the C.G. Saraya Tritaling Fellowship Award. A very noted endoscopic surgeon practicing in the Western suburbs. Next slide, please. We have with us Dr. Archana Pathak next. She has several degrees and affiliations to her credit. She has a postgraduate diploma in sonography from USA, and she is also an infertility specialist practicing at the MDLM Hospital and Research Center in Ranchi. She is an associate consultant in the Medica Super Specialty Hospital in Ranchi, served as the IT secretary of Ranchi OBGYN Society. Her areas of interest include high-risk obstetrics, infertility, adolescent health, and she's been the convener of the ROGS annual conference in 2021. Lovely to have you with us, ma'am. Next slide, please. And finally, we have with us, last but not least, Dr. Deepa Mukherjee. She is a very young, up-and-coming secretary of the Krishi OBGYN Society. She's also an executive board member of TNFOG, which is the Tamil Nadu Federation of OBGYN Societies. Has served as faculty at several conferences. She very recently conducted a very good program on breastfeeding promotion for the Krishi Society. Has several publications and presentations to her credit, and her areas of interest include infertility, endosurgery, and high-risk obstetrics and urogynecology. So welcome to all our panelists. We have representation from all over the country, West, North, Central, South, and East Zone as well. And all of you are very senior and well-known practitioners. So I'm going to cut straight to the chase. Start by sharing my screen. Usually I like to start with a quotation. Today's quotation is approximately 2,500 years old. The beginning is the most important part. And we begin with this very unique case. It's a 14-year-old girl. She is overweight, being teased at school because she has acne and visible hair on the face. A menarche was at 13 years. Periods are irregular. Biochemical investigations reveal a testosterone level of 415 and 17 OHP is 1.9. Now, critically, what is wrong? Let us start by asking whether her hyperandrogenism is because of PCOS or is it something else? And let's start by discussing what are the criteria for defining PCOS, especially in the adolescent. I see Dr. Vani nodding. Can we have you start the ball rolling, please? Please unmute yourself, ma'am.
So thank you for giving me an opportunity to be a part of the small part of the panel. So in this case, there can be three things. It can be a physiological thing, which she is having irregular menstruation, because till 2 years, the girls can have irregular menstruation. Second thing, she can have PCOS. And the third thing, which the hormone is depicting that there's a raised testosterone, so there can be a tumor as well. So physiological thing is that we need to, because the symptoms of hyperandrogenism like acne and all, they are also very common in this age group. So we need to make a diagnosis whether it is a PCOS or whether it is a physiological changes which are seen in the pubertal girls. So as she has attained menarche only in 1 year back, and we need to take a history whether she was not taking any androgenic drugs or any anti-epileptic drugs, which can also mimic as which can create a scenario as PCOS also. And then ruling out the physiological part, abnormality in menstruation, then we come to the PCOS. So PCOS is diagnosed as per as adults only. But yes, the ultrasound first is hyperandrogenemia. It can be biochemical or it can be clinical. The second thing is anovulation, which can present as irregularity in the menstruation, or a complete, it can also present as amenorrhea in some girls. Sort of the patient does not attain a menarche up to 15 years, or she is not having any menstruation after the breast buds are there almost 2 years after that. So they can present it like this also. And the third thing is, which is not being taken very regularly in the adolescent patients, that is an ultrasound diagnosis or ultrasound morphology, PCOS morphology, sir. So it is not usually taken. If we get 2 points, then it is okay, because they have this morphology very often.
So let us summarize what Madam is saying here. She's saying that yes, this patient needs to be investigated, but at the same time, you can have physiological irregularity in menses and some amount of hyperandrogenism, which occurs around the puberty, peripubertal period. Since she's had her menarche just 1 year back, by and large, we would wait for at least a couple of years for the periods to become regular. But here, because she has hyperandrogenism, we have investigated. And the classic biochemical criteria, all of us are aware, and we need 2 out of 3 for diagnosis of PCOS in an adult group. Nilima, madam, do you think that this young girl who is just 14 years old needs to have an ultrasonography to confirm whether she has PCOS?
So can go for ultrasonography to rule out some other problems also.
Yes.
And so ultrasonography is must in her, because as we are seeing the hyperandrogenic, all the hormones are raised. So to rule out PCOS also we can do, but it is not necessary, as madam has already said, that it can't be PCOS at so early stage, because she is menstruating since only 1 year or 2 years only. So, but still to rule out some other conditions, we have to go for ultrasonography.
And what kind of ultrasound would you like to offer? Should we do a transvaginal ultrasound as the guidelines recommend? Is it possible in a country like India?
No.
In
India, we have to, we will be going for abdominal only.
So the theory is different, and in practice,
in practice we have to go follow.
Tackle patients, things can be vastly different.
Yes.
So a transabdominal ultrasound would be recommended. And as you said, there can be other issues besides PCOS, which can be a cause of hyperandrogenism.
Yes.
So in your experience, what are the other differential diagnoses that we must think of before we finally say, okay, this is PCOS, because PCOS is supposed to be a diagnosis of exclusion.
Yeah.
What do you think we should look for?
We should go for her thyroid profile, and adrenal hyperplasia can also, adrenal tumor can also mimic in this way. So we should go for all the investigations regarding it. and rest, I think so. This may suffice in this age group because thyroid profile and adrenal hormones only will do it.
So hormone producing tumors, be they adrenals or sometimes even ovarian tumors can cause.
Yes. So sonography is must because of ovarian tumors only.
Absolutely. Rosa ma'am, anything further you would like to add here specifically from the adolescent point of view? We are talking about ultrasound, we are talking about biochemical investigations. Are there any other issues that we should be thinking of at this point?
So, Pratik, very well explained by the panelists, and you have really shortened the whole thing into clumps. However, when you say it's diagnosis of exclusion, we need to do a hyperprolactinemia, or I mean, to see that level, and prolactin was missed. And Cushing syndrome also, however, it is rare. I think,
yes,
these are certain things which I haven't seen in my practice of Cushing's as yet, but I'm sure we have to be looking around by doing certain tests. And also, Pratik, I think one area of WHO group 1 anovulation could be, hypothalamic pituitary ovarian failure. Sometimes when we talk about diagnosis of exclusion, I think we must be a little aware of that aspect. I say here that DHEA is not done. So I think but what you have given us here, 450 nanogram per deciliter of testosterone, easily, rules out, I would think, about only ovarian tumors, and the commonest in adolescent age group, which is a little bit 15%, not so much, is a germ cell tumors of the ovary. So I think I would like to go in that direction. And Pratik, since you said it's, what our practice is usually at the ground level at my clinic, I always have a team of an endocrinologist. I have a laparoscopic surgeon with me. We are a team, of course, beside psychologists and other things which are there necessary for an adolescent-friendly health center. So I would also like to, bring in my colleagues of an endocrinologist for this girl, because we see that it's 1 year of her, menarche. And I would also like to say further on, these cases are going to be our at-risk cases for a PCOS future on 8 years post-menarche. So she's 13. So we need to follow up with this patient because she may land up into a clear-cut PCOS. Now, I don't know her history of a premature birth, because sometimes girls, you see the fetal origin of adult disease, one of the good topics, you chaired my session in AICOG. We were talking about PCOSs. Come back to the womb and see what is the history of this girl. Is she a low birth weight girl? So we need to be a little more careful. So I'm talking a little ahead of adolescents. So these at-risk adolescents are to be really looked after. And these are according to these latest Monash, ASRM and ASHRAE guidelines that, in 2018, which we have to really keep these cases with us. So it's not just we treat the case and leave it. No, they have to be followed up. This is my view, and I would do it this way, Pratik.
Thank you, ma'am. So I think there are several excellent points that Madam has brought out. Number one, as we said, since PCOS is a diagnosis of exclusion, always rule out rarer conditions like congenital adrenal hyperplasia or Cushing syndrome or an ovarian tumor. And once those are ruled out, you may see these, of course, more commonly when you are in tertiary care or a referral institution or a large university teaching hospital. In private practice, you are less likely to see these. The next point that she brought out is that since the testosterone is right off the charts, we would say 150 or 200 is the upper limit of normal. More than 200, this is double, this is more than 400. So this goes very much in favor of an ectopic secretion of androgens, such as an adrenal tumor or an ovarian tumor. And therefore, ultrasound is mandated. Already covered whether it should be transabdominal. Now we have to be culturally sensitive when we practice the culture. Yeah. And finally, another beautiful point that she brought out is whenever we are dealing with what is suspected to be an endocrinopathy, always have an endocrinologist on your team, at least one phone call away, or if possible, try and refer the patient once so that he or she is seen once by an endocrinologist, and then that particular condition is not missed. Hypothyroidism, hyperprolactinemia has also been mentioned by analysts. These are also important conditions to consider when we are dealing with somebody so young, just 14 years old and menarche 1 year ago. Let's come to the practical management now. And here I would like to invite Riddhi to share her opinion. Whether she needs treatment, this particular patient, just 1 year from the onset of menses, needs treatment for the irregular periods per se.
That she has just started bleeding since a year, and previous panelists have also said the same thing, that it could be physiological. We wait. Actually the first line of treatment should be counseling for any PCOS patient, not just this, for any PCOS patient, to tell them that what this is exactly. So a lot of reassurance to her and the parents who are more worried than the child. We need to tell them to wait it out a little. If the child is, say, suffering from a lot of other, psychological issues, when you talk to her, you take time and talk to her, you think that maybe a good counseling session with a psychologist would also work for her. Yes, sir. I don't think she requires any medical treatment. Local, we can give her for her acne. We could give her some local.
So we'll come to the management of all those hyperandrogenism in just a couple of minutes. I want to focus on the issue of regular cycles before we go into hyperandrogenism first. Up to the age of 17 years, usually, classically, we would not start OCPs. Just give simple withdrawal bleeds for such a young. And if she doesn't get more than 3 or 4 periods in a year, that's absolutely fine. All she needs is to be told that this is just a variation of normal. She doesn't need cyclical OCs, and you normally wouldn't want to start OCs at such a young age anyway. Such a young. I see Dr. Jyoti Bali is with us. Would you agree, ma'am?
Yeah, I do agree. But again, lifestyle modification and symptomatic treatment for acne and hirsutism can be started before coming to a diagnosis also, because that is more bothersome in this age group.
We are coming. We are absolutely coming to that. Dr. Deepa, welcome to the panel. Do you think that there's something wrong with these biochemical investigations? 17-hydroxyprogesterone of 1.9. Is it abnormal? Is it not? You see.
First of all, good afternoon to the esteemed faculty, and thanks, Dr. Pratik, for having me over. I'm sorry I'm joining in the middle of my work. My regards to Dr. Rosa Oliai, ma'am. I worked with her earlier. And I personally feel, yes, this patient has a very high testosterone. Anything above 150 to 200 signals a possible tumor somewhere. As madam said, it could be ovarian, it could be adrenal, it could be elsewhere. So I would like to go ahead with another imaging like MRI. MRI or CT abdomen, where I need to look into the adrenals and the other organs as well. And as madam said, I would go for a complete endocrine profile. I want to know what the DHEA is, what is the sex hormone, binding globulin, androstenedione, etc., thyroid, prolactin, of course, to complete everything. And the management will be a team management. It will be a multidisciplinary approach, of course, involving the endocrinologist. 17 OHP is definitely slightly high. I would ensure the correct, accurate measurement would be done at a fasting state of 8 a.m. So I would like to know whether this has been done correctly, or otherwise I'd like to repeat. And the next step would be, if there is a doubt, go ahead with an ACTH stimulation test. So these are the things I would go ahead with.
This is definitely abnormal, and while we are not endocrinologists, we are ordinary OBGYNs, then endocrinologist referral would be mandated, because this is an abnormal test. I think that's the big message. We'll come back to Dr. Jyoti Bali, and she just started the discussion regarding how we treat young women who have acne, hirsutism, and obvious clinical hyperandrogenism, which is causing distress. So guide us through this and tell us how you would like to start treating this. Do you want to first document how much is the hyperandrogenism by means of some scoring system?
Yes, there is a system for hirsutism. There is a system of Ferriman-Galway's system of scoring, and for acne also there is a system of scoring. And also, once you're talking to this young girl, you know how much bothered she is with these symptoms. That also needs to be assessed as per the guidelines, because the diagnosis will take some time. She should be reassured for these symptoms as well, and started topical treatment or local treatment for these symptoms also. There is no guideline which stops us from doing that simultaneously, because that will, really bring this child around in a better way with us for treatment. Because the diagnosis finally, we know, will take some time to come forward, and then that can be taken up. So for her hirsutism, you can advise her as to what past treatment she's taken. That also should be taken into consideration, whether she was using shaving, waxing, bleaching, or whatnot. So then again, electrolysis, hair therapy, all those treatments which are available today with laser, with electrolysis, can be talked about. And for her acne, how bothersome it is also needs to be considered. And then topical treatment with some local creams, retinoid, and all those agents can be used for her acne symptoms to be relieved, because they are very important in this age group.
So I think Deepali ma'am has mentioned several of the alternatives which are available to us. I always like to also refer the patient once to a cosmetologist, because I have understood one thing several years of practice, that when you're dealing with acne and hirsutism, the problem is you can deal with what new hair growth is going to happen through all your medical therapies. But the existing hair, which is that can only be dealt with by a cosmetologist or a dermatologist. And it's always a joint approach there. It's not that they are in competition with us or they are stealing business away from us. They are taking patients away from us. It has to be a holistic approach. Rosa ma'am, I see you nodding. Please tell us what medical agents you would prefer in this young man.
Just a little earlier, I wanted to share when the question happened about the examination. I think cryptomegaly is one aspect when we examine these girls, especially with such a high testosterone, because according to the American guidelines of gynecology, they've given us certain, width should be around more than 8 or 2.5 length. This is something which we could examine actually these young girls, especially your case. And for the management, I think, see, this girl is just 14 years. She's 1 year post her, menarche. What I see here, which I would really like to pay more attention to, is her overweight. When you say overweight, that means her BMI is more than 24.9. She's not obese. She's below 30. So here I would also like to let her meet a dietitian. You see, when we tell these girls, in my experience, when you tell them decrease carbohydrate, eat this, eat that, they don't understand. They don't understand, like you and me, what is 1,500 kilo. Even I don't know. As a matter of fact, I have my own nutritionist with me. So I think it's very important. The basic thing is decreasing her weight. Weight reduction will decrease that peripheral conversion of estrogen, which is happening in the periphery, especially. She's overweight, so her abdomen will have a lot of visceral fat also she'll be having. So first thing for me would be to keep her strictly on a diet. I would also like her to join a gym. She's obese, so she has to work it out. As far as medical management of this would be, when I see that if there is a tumor, like because you see that the testosterone is on the higher side, I would definitely like to do an MRI to confirm my finding and get a laparoscopy procedure done for her, telling her the consequences if this tumor doesn't come out. Now, suppose she doesn't have the tumor and she is without, but then we have to think about treatment of, anti-androgens. In this case, I do not like to start with estrogen right away with her. We have medications like spironolactone, but I would discuss this with my endocrinologist, because again, 25 milligram, 100 milligram, 200 milligram, how much he would allow according to her weight. Because if she was a little older, I would have straight away think of giving her an OC, and I would have waited for some time, before starting an anti-androgen. But then here, we have such a high testosterone, Pratik, that I think I would just like to start with an anti-androgen with her, also along with her diet and weight reduction.
Thank you, ma'am. Very nicely summarized, saying that since the androgen levels themselves are so high, maybe we can skip a few steps in between and go direct to an anti-androgen in this particular case. That's very nicely put. Dr. Archana Pathak, ma'am, any advantage of weight loss in this peripubertal age group? Do you think that at this age when people are undergoing that state of which you call teenage rebellion, are they likely to follow a doctor's orders much more than family members' orders when you ask them to lose weight?
Yes, sir, because obesity has definitely role in this, and when the weight is reduced, the cycle is also regular. And so we can advise them about the lifestyle modification, and about the weight loss is very necessary, sir, in about for the PCOS management.
So to some extent, weight loss will help. Whether it practically translates into an actual weight loss after you have given a lot of advice, that is something which needs still to be actually assessed at the end of 3 to 6 months. Doctor,
one. So, and it is very important, sir, that they are having a metabolic syndrome. They are having, because PCOS, even in the adolescents, they have metabolic syndrome. So, if we go to the lifestyle modification, then there will be a decreased risk, or we can even
Dr. Ritik, could you tell us which is the anti-androgen that you would prefer in your practice in the western suburbs of Mumbai?
So there are two anti-androgens which have been commonly used, finasteride and cytomid. We are currently using cytomid at present, 250 mg every day, OD, for 3
What
months.
about the
It is
humble, dinogest, drospirenone, cyproterone acetate? Would you like to try these first?
Oh yes, sir. So sorry. Yes, sir.
Ritika,
Definitely.
do you find that your patients are quite accepting of being put on cyproterone or drospirenone?
She's just 14 years, so I'll have to do a lot of counseling for both the patient and the mother. The mothers are more anxious. They want to know what really is happening with their child, and probably estrogen containing, it can cause premature closure of epiphysis and other things. So I would probably go ahead, like Dr. Rosa Madam said, with some anti-androgen like finasteride or spironolactone would be my first choice, preferring also because the testosterone level is very high. So I don't know how effective the OC pills could be. In any case, if they are acceptable for OC pills, my choice would be drospirenone combination, cyclotron acetate also, but we are seeing a lot of DVTs with cyclotron acetate. So I'll have to be a little careful. I have to elicit history about family history of DVT, thrombosis, and everything. And then probably give them adequate counseling and then start off with one of the two drugs.
Yeah, so I think we've covered this particular case in exhaustive detail and we've spent time. So let's quickly summarize everything that we've learned from this case today. These are the diagnostic criteria, how they have evolved over a period of time. All of us are aware that traditionally we require 2 of these out of 3 for diagnosis of PCOS in an adult woman. For an adolescent, typically we used to say all 3 need to be present. And of course, we know that the new guideline is coming. It's not new anymore. It's now 3 years old. In August of 2018 is when it came out. This was through a combined effort of ASRM and Nash University. What the guideline recommends is that you need to use good high quality assays like LCMS to assess testosterone, which is not available in a country like India. In Western countries, this is available. Hopefully, this will happen in India in the near future as well. You need to take a comprehensive history, as Jyoti mentioned. You use the modified Ferriman-Galway score for hirsutism. You use something called as a Ludwig score for alopecia, which may rarely be seen. This Ferriman-Galway score, this chart looks like And the differential diagnosis, like we said, something which we need to rule out before we call everything and anything left, right, and center as PCOS. Just bear this in mind. These are the different options. In this particular patient, because her serum progesterone level 17 OHP was very high, than 1.7, that was the clue. This is an aberrant case of hyperandrogenism. This is NCAH, which presents late in life. Mutations are known to cause this, and this is inherited in an autosomal recessive fashion. We have already covered this, so let's not talk too much about it. COCs are recommended even in the adolescent age group, especially if the patient has hyperandrogenism, not specifically for treatment of irregular menses. If the only complaint is irregular menses, withdrawal bleeds 3 to 4 times a year are more than adequate. As far as which contraceptive is more efficacious in the Indian population is concerned, drospirenone works very well. Cyproterone acetate works even better. And cyproterone is something which has stood the test of time since nearly 4 or 5 decades. It's been available to us. And you'll find that even after 12 cycles, cyproterone shows the strongest anti-androgenic activity. There is some limited role for prescription of insulin sensitizers, metformin, and we'll come to myonisopur and declarins later on in the program. Lifestyle modification with weight loss is the primary approach, and insulin sensitizers are good. Achieve weight loss and regularity in cycles in a significant way. If you are specifically focusing on insulin sensitizers, then there are new insulin sensitizers called as myonisopur, which are available. The standard dose is about 2 to 4 grams per day, and you will not find too many papers or too many studies on these. Most of these will be small numbers of studies, and meta-analysis also will not have more than 1,000 patients, but they significantly improve the anti-androgenic profile of the patient. And these are quite safe and efficacious if used in the adolescent age group. Let's go to the next case. This is a 16-year-old girl. She is presenting with irregular cycles, has gained weight over the past 3 years. There is some disturbance in the background. Could I request whoever is speaking to please mute themselves while they are speaking? So she's gained weight over the past 2 to 3 years, especially in lockdown period. And I think that is true for all of us, including myself. I also gained weight. But this young lady is now around 90 kilos. She's suffering from anxiety. She's had panic attacks in the past month. Her mother has dragged her to you. You are her PGYN. So as a general obstetrician and gynecologist, Dr. Nilima ma'am, what are the mental health issues that we need to be aware of, and how do we actually address this particular situation?
This girl, probably she's 16 years old, and she has gained 90 kgs of weight, and her cycles are also irregular. So she needs the basic investigation, which we have already discussed in the last case regarding the PCOS. But regarding her stress management, we should discuss with her, because the weight which she has gained and the irregular cycles, these are really the mental harassment for her. And due to this, she may land up into some stress problems, like she may be eating more, or she may be going for fasting for long hours of periods, and eating habits may be changed because of the issue that she has gained weight. And this stress is really unbearable when your peer group is teasing you, and you are looking that they are more smarter than you, and you are gaining weight. So in this case, probably it is the counseling at my stage when she will come primarily to me, that regarding her weight, we should make her aware that this weight is what is disturbing her body. It is disturbing her stress, means disturbing her daily routine. Also, her cycles are also disturbed because of the weight. And we should, as she's 16 years old, that much only we can tell what she can accept. So first, I will counsel her and her mother to manage her diet, consult a proper nutritionist, and secondly, put her on proper diet plan and an exercise session regularly, minimal 45 to 1 hour daily for 5 days a week. And for her irregular cycles, we can manage with withdrawal, as you said, for 3 to 4 months. Also, she can take the withdrawal tablets. And for panic attacks, we can ask her to consult a psychiatrist for only stabilizing her this panic, which is means the stage which she is going through. These will the basic things which I will counsel her along with her parents, because this is the part where her parents should also be involved with her. They should understand what is their responsibility, and they are the only people who can help her out through this, because alone she will go again in stress.
Thank you, ma'am. Thank you. I think that is very beautifully covered. Encourage the family to come together, counsel them entirely as a group. Previous question also we had mentioned that support groups and self-help groups are of great importance, ensuring that there is constant communication. We may be seeing the patient only once in a month, but having a support group, friends, family makes a huge difference in the day-to-day life of these young people. Dr. Riddhi, what are the important points that we should be aware as clinicians as far as mental health issues in an adolescent are concerned? Sometimes it happens that you read in Google News one fine morning that some teenager has committed suicide. And the only stress factor that she had was she was a little overweight, which is not something which is a life-threatening condition. How does just being overweight lead to such serious consequences in this age group?
So it is known that in this age group, they are more likely to be depressed, have anxiety symptoms, have decreased, say maybe they feel that their quality of life is decreased with the advent of social media and social media filters. The image that they want to look like some celebrity, or they want to look pretty. So that body dysmorphic syndrome, they don't like the way they look. Also, their whole they have eating disorders, bulimia and anorexia. All these issues, I think we as clinicians should be aware of, and we should tackle it like how Dr. Nilima ma'am very well said, that counseling along with parents works the best. But what happens is when they come to us, they do get motivated maybe that day, but then they lose motivation. So we need to figure out, we need to give them targets that every time you come with this, quantify their exercising, quantify, telling them that start with basic steps, calculate your steps, and every time set targets, lose 2 kgs next time, or the next time you come, lose 3 kgs. And even if you don't lose, please come so that we can have a chat and figure out what the hindrance is. And of course, it is a multidisciplinary approach where we need to take help with a psychiatrist, a psychologist, or help of a nutritionist, or probably somebody who can teach them exercises at home.
So close follow-up and a good multidisciplinary team approach. I see Dr. Shweta has joined us. Ma'am, I know you practice mainly reproductive medicine, but I'm sure you'll have very strong views on this particular issue. Please enlighten us. We can't hear you, ma'am. Audio issues. We can't hear you.
Pratik, can I include something? Just a little.
Yes, please go.
By the time, she gets in. So I think, it's such an important topic that I'm so glad that you brought it up in this forum, because the message should go to all our colleagues, to our patients, that, such a thing is very common. Adolescents come with anxiety. This is an age group that they have to have different hormones. They have different hormonal changes. And that's why we have these adolescent-friendly health centers. Basically, part of that is counseling these girls. Now, whenever we talk about treatment to them, we need to keep in mind, especially with the guidelines that has come, ISHRE, such a beautiful guidelines which talks about whatever you do is make it goal setting for them. You don't have to tell them that in 3 months you have to decrease weight. Give them 6 months time. So set a goal with them when you're counseling them. Let it be self-monitoring. Involve them in being, monitoring themselves. And of course, to be very realistic in life, as you correctly said earlier, whatever hair is there, the old hair will never go away. They should understand that it takes 6 months for that thick hair to grow. So if they are hirsutes, they should understand the realistic part of the treatment. So be very frank with them, involve them in the treatment. And I think importantly, especially for a girl of 16 years with 90 kgs, the first thing I would think about is decrease her weight. And give her medicines to have her, besides estrogen, because that is going to, deep vein thrombosis. She should be aware of that. So we need to tackle her and here I think is, where inositol, which are nutraceuticals, could come into our help to decrease her weight. Thank you.
Ma'am, I think.
Pratik, could I add something here?
Yes, of course. Please go ahead.
I've had one or two, patients like this off late. So they do not believe that it can be done. What I did was to show them the pictures of the celebrities, name 2 celebrities to them who've gone through this. They said, can it be done? Form a support group here also. And somebody has to anchor, even if as a gynecologist, you have to anchor them, even if you are seeking help from a multidisciplinary approach. The point has to be you to connect with their psychiatrist, their psychologist, and then be a part there in this whole thing, so that, the person doesn't feel lost. That one doctor to second to third. Somebody has to anchor, and that has to be us. That onus of responsibility has to be taken to follow up this girl here.
As the primary care physician, sometimes
yes,
we are the all-in-one for that particular family.
Yeah. Job is not over because you refer to some good psychologist or a psychiatrist or a nutritionist, but then anchor point has to be you and the responsibility with you, that the patient feels there's a sense of belonging there. Once the sense of belonging is there and you proved a point that you've dealt with so much, and an example of some celebrities, if you want, I will name the celebrities also, that PCOS lost so much weight, and show them the pictures and they do believe it. And then there's a reason for them to work hard towards their health.
So practical examples and ensuring that continuous care is there, that you are available and you are approachable, goes a long way towards ameliorating these issues.
Can I add one thing?
And yes, following up with that person who's taking care of them in the gym, or maybe nutritionist, or whatever, follow-ups have to be taken, that the person feels you're aware of what's happening to her when you guided her for all this multidisciplinary approach.
True.
You can't be caught unaware on it.
Regarding the weight loss, I want to share that
yes,
a person very near and dear should be there. You should set an example of such a person.
Yes.
I myself have lost 15 to 17 kgs of weight, and so my patients are so much yeah, they just see my pictures and I explain them how I did it, and really the girls, they get motivated, and it's helpful, because the person who is close to you, they set an example for you. You can show it. Yeah, I agree with ma'am that something which is in your vision, you are really going to do it. Yeah.
Dr. Vani has raised her hand. Yes, Vani, please go ahead.
Sir, this mental issue, sir, it is a very nice case. And this girl is struggling with the 2 situations. One situation is the adolescent, because adolescent is itself so many, roller coaster, emotional roller coaster, right? So these times the girls do not come up with their thoughts with their parents even. So parents should be the friends, like friends. She should not, like, girls should not hide anything from the parents. They should be like friendly time. Even now the friends are also teasing. So she is going through, like, these girls can say everything to their friends only to feel lighter. So now her friends are also teasing. So she is into double depression and anxiety side of state. So we see that the patients with PCOS, they do have psychological, psychiatric symptoms like depression, anxiety, as in this patient, the bipolar disorder. They have somatization disorder also, because the thing which is going into their brain is affecting their body as well. So somatization is also there, and there is OCD also. OCD component is also there, and it can be like etiology can be varied things, the hormonal profile or the obesity, because obesity itself is associated with depression, sir. So for the management, sir, I will divide it into 3 parts: lifestyle modification, non-pharmacological, and pharmacological. Lifestyle modification we have discussed enough, I think, and the support system. These things are non-medical. And non-pharmacological, sir, we can go for a psychotherapy, and as madam said, Jyoti ma'am, that we should be totally anchored with the patient. We should take always a follow-up. Like, we are really bothered about you, we can take a follow-up of the patient, and we can be always in the touch with that girl, so that she feels more she has an emotional support. And then, sir, with the psychologist, endocrinologist, and with all those this activity, increasing the activity, because it has also seen that the metabolic syndrome has been decreased if the activity of the girl is increased, and she will have the same lifestyle forever, because it is a habit. It is a habit. And the third thing is the pharmacological treatment. It is seen, some studies have said that omega-3 fatty acids or vitamin D or oral contraceptives that will decrease their testosterone, and then the symptoms will decrease. And yes, one motivating factor will be there. Okay, hirsutism. I have to shave once a week. Previously, I was shaving once in 2 days. So that will motivate her to, go through it. Motivation factor is needed, sir. And that is us and the decreasing symptoms.
So quickly, Dr. Archana Pathak wants to add something, and let's move on quickly because we are
points are covered. So I would just like to add that we should work on her in a holistic manner, and like weight loss will be one of it definitely. Lifestyle modification, exercise, diet, counseling, and reassurance. Along with that, psychotherapy, and she should feel better about herself, give her self-confidence, and we can treat her in that way. And they need to be sensitively addressed, and depression and anxiety symptoms should be screened, properly assessed, and they can be managed with the health professional, and they should be aware of their impacts on emotional well-being and quality of life. And weight loss increases with this sex hormone binding globulin concentration, and it will reduce free androgen levels also. So we can educate her, self-empower, and multidisciplinary care lifestyle intervention, all are there, sir.
Thank you. So I think that's very beautifully covered by all our panelists. We as OBGYNs need to be aware that mental health issues are very common, at least in this age group, especially when you realize that the treatment is something which is long-term. There is no quick formula for overnight taking care of both weight as well as hyperandrogenism. And once that is conveyed to the patient, it takes some time to sink in. So they need continuous support, they need a system, and you are an important anchor point in that entire system. At the same time, as a clinician, we also need to be aware of something called as suicide risk. Now, when we were students, this was not taught to us much. There are certain criteria which are there. It's beyond the scope of today's discussion to talk about them, which tries to identify which patients are more at risk of attempting suicide in, say, the next 1 week or so. And these need to be prioritized. These patients need to be referred urgently, and sometimes they may need even inpatient care. As I said, it's beyond the scope of today's discussion to talk about all these things, but we need to be aware. This is one of the consensus documents which we did couple of years back when Dr. Nandita Pachekar was the FOXI president. We had an at-risk questionnaire and a checklist. We also had a 7-step guide for counseling, which is very simple and straightforward. This is the guide. Break the diagnosis to your patient. Explain what is PCOS. Emphasize the need for long-term treatment. Counsel her on various aspects of treatment. Give her different options. Explain the need to adhere to therapy, and finally talk about metabolic syndrome. We'll come to that later. But one important point which all of us need to be aware is that mental health is something which we all need to be aware of, especially because the pandemic has amplified everything that we are going through. And we ourselves have been suffering from anxiety and depression as clinicians. So imagine the status of patients who don't have access to medical health care or a qualified professional in emergency. Their state is even worse. Let's go to the next case. This is a lady who's 28 years old. Her BMI is 32. She's trying since 2 years, and she has irregular cycles. Her previous treatment records, which she has brought with her, show irregular ovulation in response to oral ovulations. Dr. Shweta, I hope you're back with us. This is good. We can hear you now. Fantastic. There are some technical issues there. So in this patient who is just 28, she's only trying since a couple of years. And for the sake of discussion, let us assume that she doesn't have any other factors like blocked tubes, like male factor, and so on and so forth. Should weight loss alone be enough to achieve ovulation and pregnancy in such a clinical setting? Yes, Dr. Shweta, please go ahead.
You presented very nicely, so nothing more left for me to rule out. And we know that even 5% of weight loss can help these patients to ovulate. So definitely BMI 32 weight loss should be one of the thing on priority without doubt. Plus, of course, the thyroid part has been taken care of. And previous treatment record showed irregular ovulation. This thing, can you explain a little bit? Irregular ovulation means sometimes she ovulates and sometimes
she ovulates, sometimes she doesn't.
So that is a very strange thing. Has she developed CC resistance or CC failure?
So we have another case for CC resistance. So we'll discuss it at that time. Here, let us just focus on weight loss as something which we don't often give enough credit. We don't give enough importance to weight loss for achieving ovulation and pregnancy alone.
Definitely, sir. I think so. There are so many patients who with weight loss do become pregnant, and if this is the only thing, definitely she needs to lose weight according to weight. It should be prioritized if other things are all well.
Thank you. Dr. Reddy, any further thoughts regarding this particular case?
Sir, she's 28 years old, and I think she does have some time. We can take out, say, at least 3 to 6 months, give it to her to try and achieve 5 to 10% of weight loss.
Very good.
And then maybe, I mean, we need to counsel her that yes, even that amount of weight loss will probably give her spontaneous ovulation, or it will respond better to oral ovulations.
Pratik, can I add here something?
Yes, ma'am.
Yeah, so I think a BMI of 32, even if she gets pregnant, she'll land up in an abortion. So I think this she should understand, that until and unless you don't lose your weight, even if an IVF specialist of our Jyoti and Shweta would like to, and you yourself would like to an IVF, it would be an abortion. So I think it's so important for this counseling part to tell the patient that you have to decrease your weight anyhow, till you, I mean, I always tell my patients, I will not going to give you any medicines until the pregnancy, until you lose your weight and you come to me. And I hope you agree with me, Jyoti and Shweta, for this.
Yes.
I think
patients who are
overweight and obese have a much higher incidence of both first trimester as well as second trimester losses, greater incidence of preterm labor and TPRM, and obstetric complications in the perimenopause period.
I think we need to explain to her here that 5% of her existing weight is not much that you're expecting out of her. So give her a timeline and follow it up in that timeline, and tell her that even if it is not weight loss to begin with, it's inch loss around the waist abdomen area. I think that also helps in, resuming her ovulation clearly, and oral drugs would help her better conceiving. Or the last resort would be ovulation induction plus then gonadotropins, then IVF. You tell her, why do we need to go till that point? So it's better you do this and get back.
We're coming to this. Dr. Archana Pathak has raised her hand. Yes.
Sir,
I'll do 180 and come back, Pratik. Give me 5 minutes then.
Jay, ma'am.
Sir, by body weight reduction, there will be correction of insulin resistance, and any treatment that reduces insulin level in both OBs, in OBs with PCOS, will have beneficial effect, and this will reduce the androgen secretion as well, and it will act as an improvement in cyclic pituitary ovarian function, and will restore the menstrual regularity and resumption of the ovulation.
So that is very good in theory. In practice, what drug are you going to prescribe? How often does it have to be taken? How long does it have to be taken? That's what the audience wants to.
Sir,
what for what, sir? Ovulation?
Weight loss.
Weight loss.
Yeah.
No,
So
I will
only
prefer
lifestyle modification and diet.
diet and
Diet
exercise.
and exercise, that will do.
Correct.
No drugs,
Diet and
sir.
exercise would be ideal, but then with a BMI of 32, she may not lose 5% weight. So maybe some insulin sensitizer would be a good option here. What do you think, Dr. Vani?
Yes, sir, we can put, if the, sir, my point is that if she is having a glucose intolerance sort of, like, we have to do a OGTT on her according, or HbA1c, like that, whichever is available.
Often whenever you do that in clinical practice, the OGTT
Sir, I
is
do it, sir. I
asking
do it.
insulin may be slightly raised.
Slightly raised. So then I think if it is not corrected by the diet and exercise, then I think we will add metformin.
Okay.
And so one thing more
How
I
much
want to add.
metformin would you like to give, and for how long?
Sorry, sir.
How much metformin would you like to give, ma'am, and for how long?
So I will start with the lower dose to see whether the patient is comfortable with this drug. So for the slow release, 500 milligram slow release tablet twice a day, and then if needed, I will just increase it to thrice a day, or I will take the help of an endocrinologist also.
Dr. Neelima, any options that you would like to offer besides?
Yes, there are options.
Myoinositol and
like that.
Cairo, we can give the masala also because
Okay.
they are proving. Yeah.
So let me ask you a practical question. Do you like the masala or do you like the isolated single agent?
I like the masala, sir, which is acting more
Which works
with
better,
good
you feel?
results. With good
Okay.
results.
And usually, how long do you need to give it?
Minimum, sir, with this BMI of 32, she will require minimum of 6 months is minimum. Maximum we can't say, sir, for her. Because if she's
Between 3 to 6
for,
months would be required.
yeah.
And so for metformin, we can continue with the pregnancy as well.
Yeah. So, Dr. Neelima, in your area where you practice in Ovary,
Yeah.
is myoinositol, dicarbonazole freely available, and how is the patient acceptance of these agents?
Yeah, it is freely available, sir, and patients are accepting it very well.
Okay.
In the
So,
sachet and the
quite
powder
happy.
form also now it is available in this that manner also. Tablets also they're accepting, and it is the counseling part which is rest on us that if we counsel them properly that this drug will help you in what way, then the patient is definitely she's going to accept it. Because regarding the weight loss, she won't accept it at the early, but giving medicines, patients are more likely to have them.
Okay. Dr. Reddy, do you find that your counseling and the patient's motivation play equal part in whatever results you want to achieve?
Sir, and you very rightly said, telling a patient of a 32 BMI, telling her that, okay, now you start losing weight and sending her just like that may not actually work. So first thing, importance of clinical examination where you look for signs of insulin resistance like acanthosis is also very important, and also telling them and showing them that, look, this is a sign of insulin resistance and now definitely you need some additional additives that can help you lose weight. So telling them this is very important. Yes, sir, definitely in my practice, I would like to start them on both glycomet as well, metformin as well as insulin, as well as inositols. What I do is I start them on a minimum dose of 500 SR for a 32 BMI. I think that would be the minimum. You step it up to TDS dose, and you can even take it up to 850 or 1 gram, say maybe TDS. As in when how the patient is tolerating. While giving them, it's very important to tell them immediately after meals and telling them that, if you have any symptoms, most often they complain of lightheadedness, headaches, or loose motions. Sometimes the tablet comes out totally, fully in their motions. So telling them that these things can be there. Please, be in constant touch, and, that follow-up is very important with them. At least I give them for 3 months, and then, see them every 3 monthly and keep motivating them to take more, and tell them that, yes, this medicine is also given in diabetics, but this is not given to you for diabetes, because you write a prescription, they go to a chemist and they say, tumko diabetes hai, this is a diabetes medicine. So you tell them that, no, this is given to you for insulin resistance, and please take this medicine despite whatever else anybody says this will help you lose weight. So I think this kind of motivation should always be there. As far as inositols is concerned, there are a lot of combinations which are available in the market. Some have completely different doses. So the ideal combination should be 40:1 of myo to D-Cairo. And such ideal combination should be given in the correct dose. Considering the cost, sometimes patients are not motivated to take it 2 times a day. You tell them 2 times, they'll end up taking 1 time. So you tell them that, okay, at least please take this correctly. Otherwise, it's counterproductive. So I think, sir, like you said, counseling is extremely important, not just leaving them at, okay, diet and weight loss on the prescription.
Thank you, ma'am. Let's have the final word from Dr. Rosa, ma'am, before we close this discussion and move to the next.
Yeah, so to my experience, Pratik, I've been doing very well. My patients are doing very well with sustained release metformin. And very well said that you start with the lowest dose. You counsel the patient that sometimes they have gastrointestinal problem. you will have a little loss of appetite. So if they are, mentally ready with it, they do it well. I mean, they're doing extremely well, my patients, on this. However, I would also like to add a vitamin D3 and a B complex, because with metformin, you have to have a little B complex added. So just to add, everybody said it beautifully, but I always add a B complex and a vitamin D3 to it. And they do very well. They have a nutritionist, and they have to be really practical to the point, and not too many medications. With myo-inositol, I do not have much of experience. My favorite has always been, since my postgraduate days, metformin. But I know it's good, nutraceutical. It's a good thing, yet to be, studied more upon. Thank you, Pratik.
So we have a lot of different perspectives and opinions from all across the country. And I'll just quickly take you through the evidence as it stands. This is a paper from Professor Rob Norman, published way back in 2000. This is a publication in the BMJ. Generally, an OBGYN publication is one which takes these kind of papers. For us to be accepted into something like BMJ or Lancet, means it has to be a good path-breaking study. And what they found is that if the BMI was between 30 and 35, the outcome of any fertility treatment is reduced straight away by 30%. So the best thing that you can do for your patient and the patient can do for herself is to lose weight. We've been talking about losing weight for the past 1 hour, but this is one simple, easy way to convince your patient and convert her into a believer. We've already talked at length about metformin. We've talked also about a lot of other different treatments which are available, and we will skip past all this. I'm going to go to the new ISHRE guideline, which says that letrozole should be considered the first choice. And we don't talk about clomifene much. And combinations of clomifene or letrozole with insulin sensitizers, by and large, will achieve the best results in patients like this who have a short time while they are trying, and usually they will not require gonadotropins. The next case is for our fertility specialist experts. This is a 32-year-old. She's anxious to conceive, trying since 5 years. She's a case of clomifene resistance. Cutting to the chase straight away. If you can see her FSH-LH, it's clearly abnormal in this case. So this being clomifene resistance, Dr. Shweta, what options would you like to offer this patient?
So in cases of clomifene resistance, PCOD, and with a BMI of 28, fine. So I think the next step which we recommend them is either to go for hysterolaparoscopy with ovarian drilling, because her LH is also raised, or to go for gonadotropin stimulation. So in between the two, if we want to decide, we also look at the semen analysis report. So if semen analysis is good enough that they have a chance of pregnancy at naturally or timed intercourse or IUI, then we push them towards laparoscopy. If the semen parameters are not good, suboptimal, then we push them towards gonadotropins, IVF. Then it would be IVF only. Okay.
Jyoti, any difference of opinion? Gonadotropins or laparoscopic ovarian drilling?
I am not a very good proponent of laparoscopic drilling. I would rather go for gonadotropins and IVF. I'm not a very fond this thing of laparoscopy. Not for drilling, at least. Laparoscopy in other cases, yes, but not for drilling per se.
Okay.
She's already 32. After laparoscopy, again, wait for 6 months. If she doesn't conceive, then, I have to justify the cost there also and answer here also. So give them a choice, but then I would guide them towards gonadotropins and IVF, as what Shweta said.
So probably the rationale behind offering her laparoscopic ovarian drilling was that the LH is quite high. It's in double. Yes. Typically, when it's more than 10, we would recommend LOD. But for a woman who is already 32 years old,
time is an important
take that under caution, and we would probably like to err on the side of caution and not ovarian drilling. If it was a younger patient, probably yes, that could be one of the options, but not at the age of 32. Dr. Shweta, yeah. Dr. Shweta, if you were to advise gonadotropins in this particular lady, which gonadotropin would you use and what dosage would you start?
So basically, I use both recombinant and HMG in my PCOD patients. And
Right.
if she's being planned for IUI, then I'll give chronic low dose protocol with 75 units of HMG or FSH, depending upon what they want to afford. And if she's going for IVF, then I'll start with 150 units.
Okay. So let's consider that this woman, she's already trying since 5 years. Probably gonadotropin stimulation with IUI would be the best way forward, practically in this case. Jyoti ma'am, would you concur with what Shweta is saying, or do you have a different?
I would definitely agree with her, but most of the time the question that comes is the cost, and the answer is that results in IUI, when you tell them the percentage and a percentage of IVF results, I leave the ball in the court of the patient, giving the actual figures for both the treatments, and then because again the age is a factor. How many months IUI? 10 to 15% per cycle, and by the time they come to 2 cycles or 3 cycles, psychologically most of the educated patients give up. So I discuss it very openly with them, and if they are okay with IVF, I would skip IUI protocols there. If they are willing, then yes. The counseling has to be documented very clearly.
Correct. Third option is also available to us, which is IVF. And then again, when you've given the choice to the patient makes the final choice. It's up to the patient once they realize what the success rates are, what is the best way forward, and how many cycles they are going to undergo treatment. We'll quickly go through the evidence as it stands. We've already covered most of the things. One important point which I wanted to discuss is what is the preferred choice of gonadotropin. Shweta feels that either the recombinant or plain HFG, both is fine. Now, for the general OBGYN, they don't understand this concept. What is recombinant? That is sometimes the patient's question. So how do you talk to your patient? How do you counsel them for recombinant? Shweta?
Sir, I follow the Van Billy's meta-analysis that live birth rate are similar whether we use HMG or FSH recombinant. Another thing is that there is a misconception that PCOD have high LH, so we should not use HMG. So these misconceptions, when we study reproductive endocrinology, I think so we know that both the things are one and the same. But, to be very frank, if the patient is too much Google savvy and patient won't understand and they think that you have to give them branded and the best injection, then I will give them recombinant, whichever company they want, Merck or Intas or whatever. I would give them that. Otherwise, if patient just wants... in all affording patients, in fact, I would prefer recombinants, okay, because the number of oocytes are also more. We get more number of blasts. This is a freeze-all cycle. So definitely like that, the cumulative pregnancy rate also increases. So many points are there. But at the same time, if I'm planning somebody for IUI or patient is not much affording or some gynecologist is, stimulating her, then I would try to keep it simple with HMG 150 so that it's not heavy on anybody's pocket.
So take-home messages, if you're doing a simple IUI cycle, probably an insulin sensitizer, a little bit of weight loss, correcting other issues like thyroid and prolactin, and a simple HFD stimulation would work probably in 9 cases out of 10. Dr. Jyoti, would you agree?
Yeah, I would.
Okay, perfect. So I think we've covered most of the important points here as far as the most recent Cochrane meta-analysis in gonadotropin is concerned. We showed that it was... Yeah, please go ahead.
I wanted to add this that I didn't mean to say that I want to do laparoscopy for drilling per se. Though her LH was borderline, I don't want that misconception to go. And especially because she's an obese PCO. If she was a lean PCO, then also maybe some logic of drilling. In obese PCO, I'm not going to do laparoscopy to drill. The purpose was if semen analysis is good and they are planning natural or this thing, though other things will be ruled out. Endometriosis might be there, adhesion might be there, and plus we can drill.
That's one of the options that you can offer a patient, not specifically this particular patient, but a couple who is suffering from clomiphene resistance. Point well taken. So the Cochrane meta-analysis says that there's no difference whether you use urinary, highly purified, or recombinant gonadotropin. HMG and FSH are both equivalent in terms of live birth rates. As far as laparoscopic ovarian drilling is concerned, In various meta-analysis and studies, it has been shown to be equivalent to simple letrozole, and there's absolutely no difference between the two. So unless you are planning to have a patient under treatment who is coming from far away, cannot fully afford a one-time procedure,
Yeah.
he cannot come cycle after cycle of
Yeah.
circulation. Maybe in such patients, this one-time procedure may be of help. The one big advantage that you have with LOD is that incidence of multiple pregnancy and the complications of multiple pregnancy are significantly lower. Whereas with gonadotropins, no matter which gonadotropin you use, you get multifollicular development, chances of multiple pregnancy occurring, preterm labor, and all the other issues are significantly much more. So this is just a couple of questions that I wanted to talk about. And Dr. Archana Pathak ma'am, I think we'll come to you. We've already talked about how inositols are now quite widely available and we are prescribing these. Patients are also quite happy. But what about other things which are sometimes part of what we call masala? N-acetylcysteine and vitamin D. What is your take on this? Do you think they help?
Yes, sir. Inositol improves the metabolic profile of women with for infertility, obesity, and hirsutism. And the recommended dose is 2 gram to 4 gram per day.
Yes.
And and in case of vitamin D, it has some beneficial effects on insulin resistance,
Yes.
but no changes in the androgen level. And it increases the first phase of insulin secretion, decreases the serum triglyceride level, and increases serum high protein density lipoprotein, as well as the
For the
cholesterol.
benefit of the audience, if I can summarize, they are beneficial. Yes. But
Yes.
how beneficial they are, you won't know until you try it out in your patient. Dr. Vani, any experience with N-acetylcysteine, chromium picolinate, and all these other things which are sometimes prescribed together?
So I have used this clomiphene and this one, sir. Myonisitol and vitamin D. I don't have any personal experience with acetylcysteine. They do work.
Anybody else on the panel has any experience with chromium, N-acetylcysteine, or these other adjuvant therapies? Not much. Okay. So as far as the glucose levels are concerned, vitamin D significantly helps in improving your ovulation and reducing your hyperinsulinemia. It also helps to restore regular cycles. It works by this parathyroid hormone pathway, which you may not be aware of. And I just thought I'll put these slides up that vitamin D is now considered a hormone in its own right. It helps to reduce the amount of obesity, also reduces the amount of insulin resistance, and by and large, these agents are seen to be beneficial. Usually they are prescribed as combination therapy. We don't have meta-analysis, we don't have randomized controlled trials. You'll have to use these in your particular patients and see if they are beneficial or not. Next, we have this case.
Pratik, in case of intolerance to metformin, addition of vitamin B12 also has been recommended.
Correct.
Yeah.
And also in metformin intolerant patients,
Yes.
sometimes switching over to inositol seems to be beneficial. Let's quickly go to the next case. This is a 32-year-old lady. She is trying to conceive since 7 years, undergone multiple cycles of treatment. Now she wants to undergo IVF. So how do we make this IVF safe and effective at the same time for the patient? What are the issues that we are dealing with? Jyoti?
Yeah. This patient is 32-year-old and she is, if I look at her AMH is 1.5, right? So that is borderline. She's not PCOS. She's an average reserve that she has for an ovary. So I would take up, you can take up any protocol for her long, or I'm not expecting OHSS here because she's not been, at least with the AMH, I'm not looking, diagnosing her as a PCOS patient. So OHS is out of my mind right now. So I could use either the long protocol or the antagonist protocol, whichever one. But if she was a PCOS patient, AMH being more than 3 nanogram, I would have only used antagonist protocol and not the long protocol. So this is what I would do, and monitor her as per our IVF that we usually monitor on day 2 and then day 6 of the cycle, and thereon and thereforth. So OHSS is not in my mind here.
Dr. Shweta, any difference of opinion?
No, I think like I use mostly antagonist protocol in my
Yes, same here.
practice, irrespective of whatever is the indication for IVF. And our threshold for freezing the embryos is very low, sir. So if it's less than 5 embryos or more than 10, I think so most of them we are freezing. And
Yes.
only in between 5 to 10, we take a call for transfer.
So let
And
me
we
put it another.
counsel
There are rare occasions when you still do fresh embryo.
very rare, yeah.
Very rare
And
nowadays.
almost sleepless we become. We have become so non-used to any OHSs.
Okay. So for the benefit of the audience, could either of you explain what is this OHSS clinic? Though we have covered it, but just
Well,
to
it's just a complication of an IVF where there's an hyperstimulation. In any case, UH means a stimulation which is, E2 is going to be high. So any patient, even if it, let's say AMH is 1.5, after all, it's just a biochemical report. But on your ultrasound monitorings, if you get that there are intermediate follicles, total number of follicles are more than 10 to 12, in that cycle, better to use a agonist trigger rather than using a HCG trigger. That's one point. And after the pickup, do not abandon the fresh transfer, even if there has been a counseling that the transfer would be there. Abandon it. Go for all freeze all cycle. And then start the patient for antagonist for 5 days, capgolin tablet, high protein diet. All the prescription should enlist all these things. And then the patient should be follow up for any symptoms of OHSS, bloating, weight gain, any kind of nausea, vomiting, a sense of breathlessness, or any unwell patient should be followed up in the clinic. So I would ensure that the clinic is absolutely OHSS free clinic. This is the only complication that an IVF specialist would dread. And give starch on, in the OT itself, you start 6% style starch. 2 wax of starch on that day, and an alternate day you call her again for a prophylactic starch, two wax. And I think this patient should, come out absolutely fine.
Perfect. So only one extra point that I would like to add there is when you start your cycle, or ideally before you start the cycle, one agent which is known to reduce the incidence of OHSS is metformin or insulin sensitizers. We've already covered all the different points. Worst possible starting dose, because your starting dose is the one that kills, because it recruits too many follicles in the early part of the FSH window. We also have some role of serum estradiol. As Jyoti said, if you get more than 10 to 15 follicles, then you ensure that you try and counsel the patient at that stage itself that we are not going to do a fresh transfer in your case and try to freeze all the embryos. Sometimes coasting helps by waiting for about 24 hours.
But a good freezing protocol in place, I don't think coasting is really out of vogue.
No,
None of us are doing coasting.
More for the OHSS. We are not going to talk much because this is not an IVF panel. We've already covered all the different points of OHSS free clinic. Just before we go to the next case, have you seen patients who you expect will hyper respond, but actually they turn out to be poor responders despite being PCOS?
Yes, many times. Many a time. Just times. One. Just out of the OT doing one.
So that happens. Sometimes the patients can force you, even though everything is fine on paper, even though your ultrasound shows not too many follicles. When you stimulate her with, say, 150 IU, because you're scared to increase it beyond 150 IU, she turns out to be a poor responder, not hyper responder. Aisa bhi hota hai. Okay, we have 2 more cases and we have time to complete these cases. So let's do this. 30-year-old. She is trying to conceive since 6 years. Weight is 110. BMI is 35. Despite multiple attempts to lose weight, she is not able to lose more than 10 kilos. These are her biochemicals. We are basically discussing the importance and relevance of bariatric surgery in this. I'm going to bring Dr. Rosa back here because she must be seeing several of these patients who have become experts thanks to these devices which we call smartphones. These smartphones have made dumb people into over smart. Dr. Rosa, your viewpoint.
Yeah, so yes, you're right. I do come across patients who come and they are the elite class who keep on having, and no matter how much you've been telling the past few years, They've been those young girls from college till now, they've come grown up, married. Now they come finally with 110 kgs. Good Lord. So you see, you can always explain to them the good and bad part of these bariatric surgeries. Now, you see, they think it is something very smooth, and past that surgery, they'll be normal. It's not like that. You have to be very practical with them, telling them how important it is. Even if they do the surgery, it should be done in a very good place. Number one. Number two, for 1 year, you cannot conceive. They should be aware of that. After conceiving, what are the complications she will have? To some extent, we can, as primary healthcare person, tell them. They should not have under the impression, they should not be under the impression that they'll have a smooth pregnancy. They may even have at the age of 30, maybe her AMH is very low, and they may have to undergo IVF. That precious pregnancy with a bariatric surgery may not land her up into premature birth and all the complications. She's definitely going to be a high-risk pregnancy anyhow after this surgery. So she should be very careful about what we are telling her. She should think twice before undergoing this surgery.
Thank you, ma'am. Can I have Dr. Riddhi's opinion on how often you would actually prescribe bariatric surgery as one of the choices for a patient like this? I'm sure being in Mumbai, practicing in Western suburbs, you must be seeing at least 1 or 2 patients every week who say, okay, I want to end up looking like XYZ Wilmax.
Yes, sir, definitely. More often than not, they've tried so hard to lose weight. And like you said over here, this patient has tried so much and lost 10 kgs and really requires motivation to do more. She's already BMI 35. So does she classify for a bariatric surgery? So these patients, when they come to us, they ask us, doctor, should I just go in for that and quickly lose weight? So like madam said, counseling is very important. The criteria for bariatric surgery going under the knife is usually BMI of more than 40, but BMI of more than 35 with any kind of metabolic syndrome, which is usually present with such PCOS, definitely gives great results as far as the metabolic syndrome gets better, and the chances of conceiving, the pregnancy rates get much better. So for this patient, yes, like madam said, please explain them the pros and cons of it. Bariatric surgery is now done with minimally invasive approach. It is no more a very technically challenging or complicated surgery. Yes, it is. The cost factor is always there, but you should also weigh it against the pros and cons of the treatments that this woman will go, or the other cost factors that she has to incur when she's not getting pregnant. So in that case, I think these things should be laid out to them. As far as complications are concerned, yes, there are complications, but also now, as opposed to the previous techniques and all, now the complication rates have also decreased. So yes, definitely, this patient could benefit with a bariatric surgery.
So bariatric is one of the options that is widely available in a large metro cities. We have Dr. Archana Pathak with us. She practices in Ranchi. Ma'am, is this option available in your city? Let's have a good broad perspective.
No, sir, not yet. It is available. I think, sir, bariatric surgery when the person is having BMI with more than 40 kgs per meter square, or if it is more than 35 with coexisting medical problem, then patient can undergo bariatric surgery. But as ma'am have already covered that it has some complication, but definitely bariatric surgery can improve the menstrual irregularity and fertility in the obese females, and it can treat the associated medical problems as well. And the pregnancy is not recommended during the first year of the surgery. And during this time, the patients sometimes may have suicidal tendency, or so they need counseling also. Counseling is also very important. Supportive mental therapies should also be given to the patient.
Okay. Dr. Shweta has some thoughts on the matter.
Actually, sir, I am from Indore, and here at Mohawk, I think so, all over India, they have the highest bariatric load. So, and even Dr. Shilpa Bhandari had undergone the surgery and all. So we are, I think so. And, I am struggling with weight loss in 15, 20 years. So I can empathize with these people. Okay. So I don't think so we should have such a narrow mind towards the surgical approach also. I have not undergone a surgery, but I'm telling you, if somebody is
about to commit a suicide or is going into depression or is feeling very bad about themselves. So, and अब नहीं है उनमें उतना, they are not that motivated. Everybody is not used to hard work and getting things done by hard work. So if they are going for surgery, पहले तो as a doctor we should be aware that it has advanced to some other level only. It is no more a very big surgery कि जो करा ली तो पता नहीं क्या हो गया. It has become a very routine like IVF, bariatric surgery. जिनको IVF लगता है is a very big thing, so they will think bariatric is also a very big thing. So don't take it otherwise, but I am telling you कि आजकल का जो generation है, they want things at speed, एकदम फटाफट, instant gratification. So maybe if you will suggest them wait, and weight loss, they will go to another doctor only.
Yes. Good perspective.
Balloon insertion is also there. So there are so many options.
Correct. So bariatric surgery is just an umbrella term for several different types of surgeries. You can have simple bands, you can have balloons, you can have sleeve gastrectomy. All of them have their own set of advantages, disadvantages. All of them have the caveat that you need to avoid pregnancy for at least 1 to 1.5 years later. Malabsorption syndromes are common. Patients who conceive even after that treatment would have some amount of complications during pregnancy as well. So these are something which, as a clinician, we need to advise our patients. Finally, the best decision and the best choice is, of course, that which the patient takes. But they should not have half-hearted tools from Dr. Google, and they should always have complete information before they arrive at their choice. As far as the guidelines are concerned, I think we are aware that there are certain advantages to laparoscopic surgery and bariatric surgery. They reduce the weight by up to 30% over a period of time. And no amount of pharmacotherapy or lifestyle modification is going to achieve that. So if you have a BMI of more than 35 or 40, then clearly the bariatric surgery needs to be the first choice of approach rather than wasting time with weight loss, diet, exercise, and combined approaches. The old guidelines which we had, these are the Indian guidelines which have been published in 2014, recommend that bariatric should be a first choice if BMI is more than 50. Today, I think we would consider a BMI of more than 40 to be the first option, bariatric surgery. The most modern ISHRE guideline published 3 years back is that this is an experimental therapy. We still wait large volume data, and there's a long list of caveats which we need to discuss with the patient before she is subjected to bariatric surgery. Now we come to the last case, and hopefully after this there will be some audience questions also which we can take. So this is a 48-year-old lady. She is conceived twice and delivered twice, so she's very fertile. So the infertility specialist can take a breather now. This lady is worried about weight gain. She's perimenopausal. She has irregular cycles. If such a woman came to me 20 years back, I would normally tell her, ये सब normal है, ऐसे ही होता है ये age में, period आपका बंद होने वाला, tension मत लो. But given the background of PCOS and fertility treatment in the past, what are the issues that we need to be aware of, and what should we advise this patient? Dr. Vani, would you like to take this?
Yes, sir. So now this scenario, the patient is 48 years and she's perimenopausal also. And she is a case of PCOS and history of infertility. These are the scenarios. So we have a differential diagnosis of perimenopausal symptoms also and PCOS. So irregular periods, irregular cycles can be a part of this thing also, perimenopause also. And so what is the weight? Can we have the weight of the patient?
She is an obese classic patient.
Okay, classic. She is an obese patient. So how will we manage her? As usual, we will first, take a thorough history, examination, rule out all the other causes, because PCOS, if we say it is a diagnosis of exclusion, so we need to exclude everything. The perimeter.
Yeah, Abhi specifically, she is worried about her weight gain and irregular cycles. So what should we tell her? Should we tell her कि ये सब normal है, सबको होता है, कोई टेंशन वाली बात नहीं है?
If she is into perimenopause or this is the weight is raised, So it can be a part of PCOS as well. So we need to define it, whether it is a perimenopausal symptom or this thing. So after taking this, after defining that it is due to PCOS only, she has a very risk factors because she is a case of metabolic syndrome.
So that is the answer that we were looking for. This could be a woman who is subjected to 20-25 years of unopposed estrogen leading to metabolic syndrome. And here we cannot just dismiss her complaints out of hand and say कि सब कुछ ठीक हो जाएगा, tension मत ले.
Yes.
We need to investigate this. Specifically, what investigations would you order in this?
So actually, these cases are more prone to have diabetes in this age group, more prone for the thyroid disorders, more prone for the dyslipidemias, more prone endometrial cancers.
Correct.
She is obese, so she is that way too, or she is prone for all these things. So for these things, we should investigate her CBC, thyroid, lipid profile, and a glucose OGTT should be done. I do it for PCOS patients. So OGTT or sugar or HbA1c, whatever is physical, and we can do a very good ultrasound to rule out the endometrial thickness. Because these patients are very much prone to have endometrial thickening because constantly the endometrium is into the exposure of high estrogen level. So they can have hyperplasias or endometrial cancers or atypical hyperplasias like that. So we need to rule out, sir. And she is having a dysfunction, abnormal uterine bleeding also. So that has to be ruled out.
Been told that. We have not been told whether she has abnormal uterine bleeding. She just has irregular cycles.
Abnormal menses, no, sir. She is having irregular cycles.
Irregular cycles need not necessarily be there. Dr. Riddhi, anything further you would like to add besides what has already been said?
I would also add just the FSH and E2 investigation to give us an idea if she is actually, when she is reaching menopause. And like Madam said, lipid profile, thyroid, prolactin, and also if need be for, these patients are also prone to any cardiovascular problems. So maybe a 2D echo just as a routine checkup.
Dr. Archana Pathak now, any thoughts on this particular case besides what has already been said?
Well, I think most of the part is covered.
Everything is done. Rosa ma'am, would you like to summarize this case?
Well, everything is very beautifully put forward. We need to also consider homocysteine, blood homocysteine, which is during the premenopause, age group especially, will be on the higher side. So she will give us a high risk case to be a metabolic syndrome with the heart issues, cardiovascular. However, when such a patient comes with irregular menses, yes, we need to have ultrasonography done and call her, and also a pap smear. I would also like to know what is a pap smear, situation, because endometrial carcinoma, okay, but even whether she has any other issues. When it comes to mind, I don't know what the case would be accordingly, would like to also give them a choice of a Mirena, an intrauterine system, which could help her out with her irregular cycles, and that could, take her beautifully. I've had very good experience with patients who, of course, if she's 45, 42, it would have been an ideal situation of giving her that choice. 48, not a bad idea to give her a choice if she's got irregular menses.
Thank you, ma'am. So I think that's neatly summarized. I'll quickly go through the evidence as it stands. Metabolic syndrome is a condition which happens when women are exposed to unopposed estrogen, as happens in PCOS for 20-25 years. There are multiple different issues which are happening at the cellular and microscopic level, which we may not always be aware of. We don't really take these into consideration, but they are happening, and these changes are additive and synergistic over a period of time. The criteria have evolved over a period of time, and this is the most recent definition. What is important for us to know as clinicians is that PCOS and metabolic syndrome go hand in hand. There is a 5 times higher risk of type 2 diabetes, twice the risk of cardiovascular disease, 2 to 4 times higher risk of stroke, 3 to 4 times increased risk of myocardial infarction, and twice greater risk of death over the next 5 to 10 years after the patient has conceived, delivered, and gone. Therefore, one of the last things that you need to talk to the patient during the PNC clinic, if at all you actually see postnatal patients, many of us just delegate it to our juniors and we avoid meeting patients in the postnatal clinic, is that once you cross the age of 35, every couple of years, we need to get evaluated. And this evaluation is very clearly defined. OGTT, as has been said already, metformin does help in these patients to reduce the amount of risk. Endometrial cancer is something which can be easily assessed today. We have very good high sensitivity ultrasound tools. Transvaginal ultrasound is easily available all over the country. It's not something which is niche, only restricted to tertiary institutions anymore. And of course, epithelial biopsy is something which is universal. As was madam said, pap smear can also sometimes pick up these endometrial cancers. We are stopping the panel here. What I want to invite the panelists to do is, before we close and wind up and we take the audience questions, to give us some of their thoughts which we may not have covered in the panel so far, something which they feel they would like to convey to the audience, which is of significance, which doesn't always get covered in a panel, something from their own personal experience, an anecdote, or something which is rare, which they found, which they experienced. We'll start with Dr. Shweta ma'am.
Sir, I think so. In our discussion, most of the things we have covered. So nothing more to add.
Okay. So we've covered most of the important issues in our panel because for we've been talking. Dr. Vani, anything specific you would like to convey to the audience?
So you have beautifully covered the panel with every aspect, taking from the morphology to, infertility to the mental scenarios, beautifully covered. And so thank you very much.
Thank you, Dr. Vani. Dr. Archana Pathak, ma'am, any thoughts?
Sir, you have covered almost all the topics, sir, in this regard. I think.
Kuch okay. Full coverage. Dr. Riddhi, ma'am?
Sir, again, like all our esteemed panelists have said that it's been beautifully covered. It's just that I think due to paucity of time, we could not talk more about aromatase inhibitors. I think letrozole, like all the panelists agreed in that case that yes, we should go in for gonadotropins. Usage of letrozole plus gonadotropins would definitely be beneficial in CC resistant cases and can decrease the cost also of the whole cycle for patients.
Absolutely. Probably that is the preferred protocol for IUI in the vast majority of patients in small clinics which are standalone clinics. Rosa ma'am, your thoughts please.
Pratik, congratulations. One of the very best PCO panels that I've really attended so far, past 2 years in the pandemic Zoom. You've selected beautiful panelists here, all of them, one and all. Excellent. We had crush of, opinions, which is really good for a panel discussion. And things I like was everybody talked about their clinical aspect, their own experience. Excellent. All of us sitting here together and wish all the best for future such kind of panel discussions. And the one thing which I want the audience and all of us should think about is having these PCOD clinics. I know, Pratik, you've been doing a lot of work guidelines regarding that. So if you could, spearhead, this, and in all societies, we could have a PCOS clinic, which could be linked with an IVF specialist or an endocrinologist, that would be wonderful. And help support group, which is very, very important. And I was very happy that you brought up these mental issues, which is so very much apt nowadays with the corona pandemic. All of us are, you correctly said, even the physicians, we have cases who have come with high-risk pregnancies, complications. We have got our own kind of, obstacles in life, and we should be healthy ourselves first, and then we can, treat the other patients. Thank you so much, Pratik. Thank you so much, all my panelists, that you all were co-panelists. Shweta, Jyoti.
Thank you, Rosa ma'am, and thank you, Dr. Pratik, and everybody there. It was a wonderful panel. Learned a lot out of it.
Dr. Deepa, any closing remarks? Any final thoughts? I think you were away with an emergency. We're just closing the panel with some final thoughts. Anything you want to convey to the audience?
Sorry, am I audible?
Yes, ma'am, you're audible. Please go ahead.
I can't hear you. I'm sorry. I have some problems with the connection.
Okay, no worries. I think we have a couple
I think
of.
I missed a great panel. I'm so sorry. I had to take a short break because of some emergency. But I really loved the first question where you summarized the whole thing beautifully. I think the panelists did a great job. I really missed this one. I'm so sorry.
No worries.
Thanks for having me over, but I'm so sorry.
Wonderful to have all of you. There are a couple of audience questions before we close and before I present the vote of thanks. There's one question which is asking how long is inositol to be given and can we give it in young girls as well since it's expensive. This is Dr. Aditi Lad from Indore. Dr. Shweta, you want to take that?
I really can't hear.
Inositol is, as per evidence, still an experimental drug. I would say I prefer giving metformin.
Yeah. So as far as the evidence is concerned, usually the guidelines recommend metformin. Inositols are widely available. Unfortunately, we don't have large data. Whatever meta-analysis we have has small amount of patients and fewer data, studies are available. They are well tolerated, especially if you have patients who are adolescents, if you have patients who are metformin intolerant, and of course, patients who have metabolic syndrome are excellent choices for insulin sensitizers in general and inositols in particular. Typically, you would need to prescribe these for at least 3 to 6 cycles before you see benefit, and having a combined approach with diet and exercise also would make a huge difference. The second question that we have is regarding gonadotropin dosages in infertility patients. What would be the gonadotropin dose that you would recommend in PCO patients? Dr. Jyoti, you want to take that?
That would depend upon the age of the patient, BMI, AFC, and your previous stimulation record, if any, put together, and then you decide the dose.
So one size never fits all.
Pardon?
The take-home message is that one size never fits all.
It has to be personalized treatment and individualized and not generalized.
Absolutely.
It is individualized protocols these days that we tailor-made protocols to each patient.
Thank you, ma'am. So that's the, yes, ma'am.
So in PCOD also, we do have to raise the dose of gonadotropins also. You know, we start with 150. We may go up to 300 and beyond also.
Maximum would be 300.
Number of days of stimulation can go up to like 18, 19 also. We have done such cycles and got success. So those things have to be kept in mind.
Yes.
Not every PCO is a hyper responder. You can also have poor responder PCO. So be aware. Again, as you do more number of cycles, then you will come across these kind of clinical situations and scenarios. So at the end, I'd like to present the formal official vote of thanks. Thanks to all my wonderful panelists for contributing so wonderfully, despite it being a weekday afternoon program. Let me start by expressing my gratitude to our President, Dr. Nandita Palchhatri, President of the MOGS, Dr. Arun Nayak, our Secretary of the MOGS, the ICOG Chairperson, Dr. Uday Thanawala, the Secretary of ICOG, Dr. Kumar. Thank you for the ICOG credit point. Our 8 wonderful panelists, Dr. Rosa Oria from Gwalior, Dr. Jyoti Bali from Delhi, Dr. Manipuri from Ghaziabad, Dr. Shweta Kaur Jha from Indore, Dr. Nilima Atta from Amravati. She was called away for a patient and she had to excuse herself in between. Dr. Riddhi Desai from Mumbai, Western Suburbs, Dr. Archana Pathak from Ranchi, and Dr. Deepa from Trichy. Excellent. A lot of congratulatory messages from the and 500 viewers who are for this event. I have to thank our academic partners, Integra, Subbu and Session, and work, and Documentus Viviana for the academic grant for today. So until next time, goodbye, God bless, and wish you all the best. Bye.
Thank you so much, Pratik.
Thank you.
Thank you, everybody.
Thank you so much.
Thank you so much, sir, for a great panel. Thank you all.
Yeah, please keep on making us part of such meaningful.
Yes, sir. Exactly.
से बाहर निकलोगे तो भी ना आप ऊटी से बाहर थोड़ी निकलते हो
अरे नहीं सर बिल्कुल बाहर ही है सर.
Looking forward, sir, for more panels like that. So interactive. Thank you very much. Thank you, Rosa ma'am. Thank you.
Thank you, Rosa ma'am.
Thank you, everyone. Thank
So
you
thank
so
you,
much.
everyone. Thank you, sir. And very, very sorry. I had to go for an emergency in between. I'm
No
so
worries.
sorry.
It was
Dr.
lovely.
Deepa, we missed you.
I really missed all the panelists. It was lovely. Rosa ma'am, my regards to you.
Thank you, Deepa. Lovely to have you here, although you were busy. Lovely.
Thank you. Thank you.
All of you, wonderful. Hope to see you all in person very soon.
Yes.
Yes, ma'am. Yes. Looking forward, ma'am.
Thank you. Bye-bye, everyone.
Bye-bye all.
Bye-bye.
Bye-bye.
Bye, everyone.